and my dear friends. I have been asked to speak on early experience with Melody. As you know that this is a teamwork, and I think you require a excellent team comprising of anesthesiologists, intensivists, cardiac surgeons, cardiologists, of course, and many other supportive staff, nurses and technicians, and a good proctor. And we were proctored by Stefan Schubert from Berlin. And I'll show you some of the cases which we did and the experience that we had getting proctored by him. So the heart team should also comprise of hospital administration because it requires a lot of financial support. Of course, referring consultants who must have adequate faith in your experience and expertise, and then some of the other specialties like radiology, and as I said, surgical colleagues, anesthesiology, intensive care specialists, nurses, and technical staffs. As has been shown to you by Shiva, most of the patients requiring percutaneous pulmonary valves are either symptomatic, or if they are asymptomatic and the lesion is predominantly stenotic, then RV pressure should be more than 2/3 the systemic pressure. And if it is regurgitant, I think most of the criteria are MRI based, mainly comprising the right ventricular end diastolic volume, right ventricular contractility, and pulmonary regurgitant fraction. As far as the prerequisites are concerned for conduit size or bioprosthetic valve, you can do it up to 32 millimeters, and the RVOT size of up to 34 millimeters if it is a native right ventricular outflow tract, and this 34 millimeters is by balloon sizing. As far as percutaneous valves for conduit or bioprosthetic valve dysfunction is concerned, I think we have Melody, Sapien, and MyValve, and for native RVOT, as was said earlier, we have Venus, P, Pulstar, Harmony, Altera, Sapien, and our own MyValve. So I'm going to speak on our early experience with Melody, and for that, I think you need to have a conduit size which is more than 18 to get reasonably good hemodynamics, and ideally to 22 or 24 millimeters. But anything more than 24 millimeters is, I think, beyond the realms of Melody valve. Smaller conduits can be dilated to larger sizes, certainly, but I think at the cost of conduit rupture. And I think amongst all the conduits, you need to be extremely careful about the heavily calcified homographs because they have the highest risk of rupture. So this is our experience of 9 patients here, and there is one more patient done after this. The youngest has been 16 years and the oldest has been 76 years. There have been 3 females and rest of them have been males. Most of them have been symptomatic, class 2 to class 3, excepting this old lady who came in class 4 NYHA. The preceding surgeries have been anywhere between 1 to 4, and most of them have had pulmonary stenosis with pulmonary regurgitation. All of them had systemic right ventricular pressures, excepting one with a suprasystemic pressure. And most of them had their melodies deployed on 20 or 22 ensemble. So I'll just share a couple of cases with you. This is a 31-year-old with tetralogy of Fallot and pulmonary atresia, had RVPA conduit in 1999 with a fenestrated VSD, went back in 2000 for VSD closure with MAPCA ligation, had a surgery for tracheoesophageal fistula in 2001, and a redo replacement in 2005, then came with NYHA class 2. And had a conduit dysfunction with severe PS and of course pulmonary regurgitation as well. And you can see that the right ventricular pressure is almost systemic. So this is the, so none of these are going to play. They were playing when I played them. Think that anything is playing here. So I think this was a case with a significant calcification of the conduit, and this is the balloon which has been used to interrogate the conduit stenosis as well as to interrogate the coronaries in the beginning. Subsequently, once we found that there was a severe stenosis somewhere here and the coronaries were far away, we didn't go on to interrogating the coronary in a big way because of the calcification. The only reason we used a balloon here before putting a covered stent, because this patient had previous 3 surgeries. So I think the chances of any uncontained rupture was really very, very small. So this is the covered stent being put in. The covered stent is post-dilated with Atlas and confirmed that there was no compression of coronaries at that time. Further dilatation with Atlas, and this was a beautiful landing zone shown in PA and in lateral projection. And then we found that the right ventricular pressure was almost 40% of the systemic pressure at this juncture. So we are happy with the creation of the landing zone. There goes the Melody, and there goes the outer balloon of the Melody. And this is the final picture or final hemodynamics. You can see that the gradient of around 10 to 12 millimeters across the right ventricular outflow tract with right ventricular pressure of less than 30% of the systemic pressure. And these are the final angiograms with no pulmonary regurgitation. So this is a second case of truncus repair with RVPA interposition graft. There was a redo conduit replacement with 20 millimeter bovine pericardial conduit done in 2008. There was an attempt made for balloon dilatation and stenting of the pulmonary arteries, but that was an unsuccessful procedure because we couldn't get the long sheath across the narrow conduit. This patient also presented with NYHA class 2 to 3, severe stenosis here, and there was a free regurgitation on the echo. So none of the movies are working. I'm sorry for that. So this is a severe calcification you can see, and there is a branch PA stenosis here. And if you look at this, the minimum diameter of this conduit has come to 9 millimeters. And at this particular point where there was a severe narrowing, it is 9 by 15 millimeters. And if you look at the pulmonary arteries, they are around 8 millimeters on the left side and 9 millimeters on the right side. This is a 3D reconstruction showing you the narrowing at the origin of the pulmonary arteries. So this is the baseline hemodynamics, baseline aorta with left pulmonary artery, and then we bring it back to the main pulmonary artery and then bring it back further to the from right pulmonary artery again to the main pulmonary artery, significant stenosis there, and from main pulmonary artery into the right ventricle being systemic. So this is the level of calcification here, and this is the angiogram in lateral. This is an angiogram in PA projection. We tried to get the sheath across. We used initially the Mullins sheath, but it just wouldn't go. Then we went on to the braided de Villiers sheath, and we tried to get the sheath in. But as you see here with the Lundquist wire, although inferiorly was located anteriorly, and therefore this sheath could not go in. We got this wire out. We repositioned the wire posteriorly and inferiorly, and with the help of the balloon rather than a dilator, we could get the sheath across. Once the sheath was across, we used a covered stent here to prepare a landing zone. After preparing the landing zone, the covered stent was post-dilated with Atlas gold, and this was the pressure in the main pulmonary artery, and this was the pressure in the right ventricle. So you can see that now the systemic pressure is around 130, whereas the right ventricular pressure is around 60. And the gradient across the conduit was around 15 to 20 millimeters. So after this, we decided to do a good angiogram, and the angiogram showed that there was a significant stenosis of branch PAs. So there was a lot of debate on this, whether to stent these branch PAs, but we thought that it might come in the way of the deployment of the Melody. So we thought that we will just dilate with the high pressure balloon. And so Mustang 12 millimeters was used on either side. And it did not produce a perfect result, but definitely there was a significant improvement in the luminal diameter, and the flow also improved significantly. So after that, we put in the Melody, and we saw that the Melody was tracked in exactly brought in the center of the landing zone, and then was deployed with smaller balloon first and larger balloon thereafter. So this is the final hemodynamics. You can see that the aorta is around 110 to 120, whereas the main pulmonary artery is around 50, and the RV pressure may be around 60. So a gradient of around 10 millimeters across the conduit. And this was the final angiogram showing no pulmonary regurgitation at all. So the lessons we learned, especially from this case, is that there are a lot of challenges in planning. And when you have associated branch PS stenosis, I think things become even worse. So I think the issues here, when you have branch PS stenosis, whether to address or not to address, when to address them before putting an initial stent or after.
Last 7-8
And how to address them, whether with a balloon only or whether with one stent and just opening the other PA from the side strut, or whether to put in 2 stents and then prepare a landing zone with maybe an additional stent lower down. The challenges in execution, tracking the large and long sheets, which was emphasized by Shiva. I think getting a good guide wire position using braided sheets like DeVilliers sheet and having balloon support instead of dilator can make these difficult things relatively simpler. So in conclusions, ladies and gentlemen, each of the cases is technically challenging. Some are more challenging, some are less challenging. I think good proctoring and hand holding is extremely essential, and we are thankful to Stefan Schubert for having helped us with our early cases. This is a very expensive proposition, and therefore having a meaningful program in a country like India, I think will take quite a bit of time, and therefore gaining good experience is difficult. I think we are almost always on the learning curve because we do this procedure so infrequently. I think the solution to this is to bring down the costs. So we need to develop an affordable valve, which at this juncture seems to be a distant dream. Thanks for your patient hearing, ladies and gentlemen.